So to reiterate, the purpose of Senate Bill 1063 is to amend the Public Health Service Act to establish direct care registered nurse-to-patient staffing ratio requirements in hospitals and for other purposes. The bill was introduced by Senator Sherrod Brown on May 4th, 2017. It's been co-sponsored by Senator Elizabeth Warren, Senator Tammy Baldwin, and Senator Bernie Sanders. Related bill includes the United States House of Representatives Bill 2392, which is the Nurse Staffing Standards for Hospital Patient Safety and Quality Care Act of 2017. It essentially has the same verbiage as Senate Bill 1063. And Senate bill was introduced and read twice on May 4th, 2017, and has been referred to the Committee on Health, Education, Labor, and Pensions. The issue is inappropriate nurse-to-patient staffing, which may lead to poorer patient outcomes, nurse recruitment, nurse retention. History and background. Nurse staffing is a crucial health policy issue on which there is a great deal of consensus on an abstract level that nurses are an important component of the healthcare delivery system and that nurse staffing has impacts on safety. There may be an association between higher levels of nurse staffing and improved patient outcomes, including mortality rate. The registered nurses, the nursing profession in general is currently 3 million strong, but that statistic is merely the amount of nurses that are currently practicing. There are increased numbers of nurses, but unfortunately not all that are licensed are practicing, and some speculate that that is because of the current way that it is structured with staffing, taking into account burnout. Summary: hospitals would be required to have a staffing plan that complies with the mandated ratios. Hospitals would also have to post a notice regarding the ratios on each unit, and they would have to maintain a record of ratios for each shift. Medicare payments would need to be adjusted to hospitals to cover additional costs due to compliance to ratios, including increased staff. Nurses may object to or refuse an assignment if it violates ratios or if it's not prepared or if they are not prepared either by education or experience. So if you are essentially not comfortable taking care of a patient that is on a ventilator because you have not had any prior experience, you would be supported by this legislation to decline to take the assignment for fear of patient safety, as well as your own license. And hospitals may not take action or discriminate against a nurse based on the nurse's refusal to accept an assignment for such a reason. And the Department of Health and Human Services would need to publish names of hospitals that have been penalized for violating the bill's requirements. Some unintended consequences could include the black and white limit on assignments in general. The numbers don't always reflect acuity or background of the assignment in general. There could be worsening staffing shortages depending on how the hospital chose to either implement or not implement the legislation. Increased financial stress in the facilities due to the need for more staff. Patients admitted to inappropriate units in order to comply with the ratios. Perhaps a patient that is meant for a higher acuity unit may not be assigned to that unit for fear of violating the ratios, and then the patient and potentially the nurse would be at risk. Ancillary staffing shortages. With hiring additional nurses, hospitals may choose to lay off or eliminate nursing assistants, telemetry techs, nurse techs, and other ancillary positions, and there could be continued nurse burnout and poor patient outcomes if the bill is not passed. So essentially, this is one measure to try to fix one of the issues in healthcare. Some fiscal information. Hospitals with higher nurse staffing had 20% lower odds of having to pay readmission penalties. As we all know, Medicare does have penalties that are incurred against the hospital, such as no reimbursement at all for 30-day hospital readmissions for chronic issues such as congestive heart failure. So some hospitals that have increased their staffing have seen a decrease in the readmission penalties. A majority of research shows staffing ratios are cost effective, even though there could be an increase in cost to the additional nurses. If we can improve outcomes, we will end up reducing cost in other areas. High turnover rates and high levels of temporary nurse staffing can increase the average cost per discharge, cost of an inpatient care including administration and overall operation costs. For example, there are some facilities who have staffing shortages that rely on traveling nurses such as myself, and the bill rates for such employees do come pretty steep at times. So increasing staffing with local nurses in the area would be cheaper in the long run than to continue to need traveling nurses. So it may actually just end up balancing out if there is more appropriate staffing. Stakeholders are essentially everybody, but some main ones to touch on are the patients themselves. They are the direct recipients of the care. Who doesn't want a little bit more attention from your nurse, and who hasn't felt, either as a patient or as a nurse, that not enough time has been spent. It's something we're taught in school, and something that we want to be able to do is that hands-on direct patient care, which makes us also stakeholders. We want to feel that our employers support us. We don't want to feel burned out. We want to be able to provide quality care to our patients. So that's a big motivator for us to push for this legislation. Administrators are also stakeholders. They are responsible for their patient satisfaction scores. They are responsible for their employee satisfaction. They are also in charge of financial expenditures and the staffing itself. And we all know how word of mouth can dictate a lot of things as far as care goes. If your hospital has a good reputation, safe staffing, you're going to attract talent to your company. You're going to attract patients because they know that they will get quality care and the kind of attention that they feel they need. And Medicare is also a stakeholder in the fact that they are an insurance company, so they do have a lot of expenditure. There's a lot of chronic disease. There's a lot of baby boomers, so right now their expenses are quite extensive. And to reduce the amount of penalties that they have to incur and to improve their reimbursement, it can be a plus and a minus for them. But we would hope that it would be a huge plus to reduce the amount of readmission and rates and improve care. So the recommendation is that ratios should be a guideline. Not sure that the black and white law would be most appropriate. I can see where that would be kind of a problem when acuity, patient background isn't necessarily taken into account. It simply means if you're admitted to an ICU unit, you're only allowed to have 1-to-1 ratio or 1-to-2 ratio. So that may cause some issue. Insurance companies such as Medicare should reimburse the facilities who follow recommended ratios, since there is evidence that shows that it improves patient outcomes, including mortality and quality of living, status post-MI, and joint replacements as well, which are huge expenditures for Medicare. So instead of perhaps making it a black and white that every facility needs to follow these specific numbers, perhaps passing recommended guidelines for the numbers and encouraging reimbursement sources such as Medicare to sort of penalize the hospitals that opt not to follow the guidelines, because they could be incurring more cost by not taking care of their patients as well, which kind of puts the ball in the park of the hospital or the facility. If they would like to receive better reimbursement, they're going to have to improve their staffing and take care of their patients better. Nurses should be supported by legislation, the ability to decline an assignment based on patient safety and acuity without fear of retaliation. We've all had those days where we feel that we were stretched a little too thin, and we should be supported by legislation when we feel we have to speak up for the safety of our patients and our licenses. There should not be any retaliation if there is valid evidence to support that our assignment is inappropriate. So that is my presentation. I apologize for my voice. I'm battling a bit of a cold. And I welcome your feedback. Thanks, everyone.